evening, the university is closed, and a policy has taken hold that when the university is closed, we can't have classes either, even if they are virtual, which is too bad because we did have a lot that we were going to cover this evening, which is, I'm sure, true for every class when we only meet every other week. So I am recording a lecture for this evening. There are going to be various points where I will point out something that instead of having you talk about in a class discussion, I'm going to have you submit in written form. Um, so that's my plan for how we will make up for not being together today. I'm going to start by, I'm always going to have a PowerPoint. It's one thing about me. I don't know what I'm talking about if I don't have a PowerPoint. And um, sometimes I forget what the next slide in the PowerPoint is, and it's a surprise to us all. Tonight, I feel like I'm pretty confident what I put in here. Um, all right. So this is technically class two. Unfortunately, we will all actually meet on class four. Um, but a little agenda. Again, this was you're supposed if you want to take a 10-minute break at any point during this video, you can by pausing the video. So I'm not actually going to take a 10-minute break. But the things that I want to go over are a bit of a intro. I was hoping to get intros to all of you, but it'll just be an intro to me this evening. Talk a little bit about the syllabus and Canvas, and then just talk about some key concepts in assessment, diagnosis, and treatment planning. And then we'll talk about what will be due for week, September 16th. Okay, never mind. This the slides are usually accurate. This one is not. What'll be due for weeks three and then for week four. Week three being asynchronous, week four being when we are back together in person, none of those being September 16th. All right, so me, my pronouns are she, her. I am not an LMHC. I'm actually an LICSW. My background is in social work. I have experience in community mental health at a couple of different organizations, and right now I am an outpatient therapist at a group practice, but that will only be true for the next 2.5 weeks, and then I am actually leaving the group practice and going into private practice, which I am very excited about. At Framingham State, I teach a couple of classes. I am also one of the program coordinators. So for half of our cohorts, I am the Bonnie Sherman for them. So I know this program very well. Um, my style is humor and humility. I do have a graduate assistant working with me. Her name is Lucille Fleming. These are two pictures of her. Her hobbies are playing fetch with specifically the orange rubber chucket. No other ball will do. And her other hobby is pretending to be dead on walks so that people stop in their car and ask me if my dog is okay. She does all of the grading and she also does the PowerPoint preparation. So, for instance, something like getting the date wrong, September 16th, that was Lucy's fault. So I will have words with her afterwards. My hobbies are that I love working out. Another one of my jobs is as a personal trainer. I love spending time in the gym, and I've recently learned that my only other hobby is consuming all content heated rivalry related, and that's all that I care about. Um, so if you ever want to totally derail me from a lecture, just bring up heated rivalry in any way, and I will talk about that for hours. And if you haven't seen Heated Rivalry, I would like to take this moment to encourage you to watch it. All right, that is me. Um, Okay, I want to talk a bit about Canvas because you'll be navigating Canvas a lot to find the materials for this course. So, this is what our home page looks like. I do my best to put in due dates for all of the assignments so that they will pop up uh, on that right-hand column where it tells you what is due. Um, it is also, I also post announcements sometimes. Like you can see our tragic little announcement that class was canceled tonight. Um, I'm going to stop sharing quickly and then actually go to Canvas. Okay, so this is that page, our Canvas site. The most important thing is modules. Modules is where I put everything. So under core materials, I've got the syllabus, the DSM-5 TR, you'll need that a lot. And then two texts that we'll be using. One is Essentials of Treatment Planning, and one is Clinical Interviewing. So you can always find those there. Um, but then you'll also find, particularly for our asynchronous weeks, and I'm going to focus on week 3 since that's what's coming up next. I will always have a start here page that will apparently always be horribly formatted. And on the Start Here page is where you can find everything related to that week. So this is the assignment that will be due next Tuesday. These are the readings for next Tuesday. And then this is the activities for the week. So we have a bunch of videos to watch. That is often what your asynchronous weeks will be videos and then some assignment related to the video. So the videos, the ineffective physician, the effective physician, motivational interviewing, emotional interviewing approaches are all pretty short. The bulk of what you'll be doing will be watching the sample assessment session, and then you will be doing a write-up from that session, which is for some reason broken into 3 parts. So that is where you can find everything for the asynchronous week, but I do also put in the readings for that week. These do not link to chapter 4 and chapter 2. They just link to the general text for you to scroll and then find that. But I thought it would be helpful if I put what chapter to read in the title here. And then the assignment will be listed here in module as well. And then for February 4th, when we do all meet, you'll see here is the reading to do for that, and then the videos that I want you to do. And then I will kind of release 2 weeks at a time of our course material. So that is Canvas. The syllabus is here as well. Important to note when we're meeting and when we are not meeting. And then other big thing about the syllabus is that I recommend looking over our course calendar just to see, what is due when, what weeks have a lot of reading. We've got a spring break week in there. So just good to kind of see. I don't tend to deviate from this at this point. So this will be a good resource to see what is to come in the class. And now I'm going to go back to my PowerPoint. Am I in the right PowerPoint? Don't tell me I have two. I do. Okay, that's fine. Um, okay. Other quick notes about the syllabus are the importance of attendance and participation, especially since we're even down one more class period that we get to spend together. So please, please, please do your best to come to class, video on, ready to engage. Going back to kind of the course calendar, you don't have a midterm and a final. You don't have any super huge projects. The projects all the assignments are kind of evenly split throughout the semester. The biggest thing is the semester project that, again, we break down throughout the semester. So that is what I asked you to submit a character um, for this evening. And basically, we'll be going through assessing, diagnosing, and creating a treatment plan for that fictional character. So, for instance, you might have chosen, hopefully, someone chose to do Shane Hollander or Ilya Rozanov. So, throughout the semester, you would be writing up the assessment for Shane, writing up what you might diagnose Shane with, and then creating a treatment plan for Shane. Um, Please, someone do that. If you are like, oh, yeah, I would, but I already submitted a different name, go change it. Change it. Email me and be like, Sarah, actually, I want to write about Shane. I think the only downside to doing that for those who are lost, he is one of the main characters of Heated Rivalry. Um, the only downside is that if you try to say, like, we don't know Shane's mom's name, I will be like, excuse me, yes, we do. How could you forget about Una Hollander, our favorite momager? Because I know all the details. Okay, anyways, again, going back to the syllabus, some weeks are a little heavier in reading and assignments. So I recommend planning accordingly. And then of increasing importance over the course of the semester, um, my favorite animal is the North American beaver, as pictured here. This is actually a picture from the Ipswich Watershed Association. Ipswich is a town in Northeast Massachusetts, about an hour north of Boston, and they are doing some great work in how to manage beaver populations in the area in a way that is humane and supports positive relationships between human and beavers. So, um, beavers are great. Okay. Now I was going to have you split into group. No, wait, sorry. That's next. First, I was going to remind us that we all have varied backgrounds in assessment, diagnosis, and treatment planning coming into this class. Um, I know that everyone has the experience of the previous classes that you've taken, and I know for some people, assessment, diagnosis, and treatment planning come up a lot in your work, and for some people, it doesn't come up as much or at all in the work that you do in your full-time jobs. So that's totally, both are totally okay. And we have a lot to learn from each other. So please ask questions. And I like to create a learning environment where people also feel empowered to answer questions that come up. Try it out. See if you know what the answer is. I'm not the only one who has insights or experiences for us all to draw from. And that I hope will become the culture of the class that feels like a place where we can participate, we can bring questions, and we can try things out. So this is where initially I was going to have you in small groups, but we will now be doing individually, is I'm going to have you write out how you would define assessment, what the goal of assessment is, what information are you trying to gather. And I have you write out how would you define diagnosis, what is the diagnosis, and what were the highlights of what you learned in psychopathology. And then lastly, I'll have you define treatment planning and what is the goal of a treatment plan. Um, so ideally, you would pause the video here and then write this all out. Um, we'll If you don't, that's okay. But I do later answer the question, what information are we trying to gather? Because I go over the biopsychosocial assessment that we'll be doing in class. But this is part one of, I've determined 3 parts of what you will be submitting for this class, for our asynchronous work. So, part one, and we're going to move on. Um, this is now a rhetorical question that I just ask out into the empty room that I'm in. Is anyone familiar with the term the golden thread? And what does it mean? I love the term the golden thread. Yeah, I do. I love it. And I think that the golden thread is the most important part of this class is understanding the concept of the golden thread. It's not super concrete understanding what I mean by this. Um, and I think it's really important. So the golden thread is, as you can see in this image, what connects everything that we're doing. And I think really maybe another word for the golden thread would be the case conceptualization, which is our hypothesis of what is going on for this client, what underlies the challenges that this client is experiencing and the work that this client wants to do. So we determine the golden thread beginning with the assessment and identifying the critical needs of the individual. So we gather up all of this information, trying to understand the person. What are the needs? What is it they want to work on? Right. And then once we understand what it is that that person really wants to work on and would benefit from and feels motivated to do, we move on to creating goals and objectives that address the concerns of the individual. We co-create this with the client, preferably. And this is all really where treatment starts. It starts once we've got a goal and objective and we know what we're working on and how we're going to get there. And then throughout the course of treatment, we have to look at the progress we're making towards the identified goals and objectives. Are we actually working towards the right things? Are we working, is the work that we're doing leading to the outcomes that we hoped? Right. And then we have the option to review the treatment plan and assessment and update them. Sometimes we update assessments when we learn more information about a client. Sometimes we update the treatment plan when we figure out, oh, we weren't really working on what the underlying issue is here. Or maybe it's we created goals and objectives and we met those objectives and we need new ones because there's some more work to do. So again, the golden thread is kind of how do we understand the work that we're doing with the client? We'll revisit this a lot when we talk about case formulation, or the hypothesis that we create about the client. Um, I wish this class was called Assessment, Case Formulation, and Treatment Planning because um, you will learn about me that I don't give a really big hoot about diagnosis. I diagnose people in my work, and I am not the kind of clinician who cares 3,000% if I did it, if I exactly got it right. What do I mean by that? I mean that most people that I work with, I'm like, they have anxiety. They may not really have anxiety. They might have OCD. But at the end of the day, do I really care if I wrote down anxiety or OCD? Like, no, I don't because I care about what am I working on. Generally, what I'm working on with the clients is pretty consistent, even if I'm like, oh, these anxious thoughts are actually paired with a compulsion. So this is OCD. I think it really matters, like, do we understand our client? Because what we're treating is not a diagnosis. Just because someone has anxiety, I'm not like, okay, I'm treating anxiety. Here's an anxiety treatment plan. I'm not doing that because anxiety can look so different for each client, right? Like, if I had, you know, teenage client really anxious about the grades that she got at school. And so our work was really building her self-esteem and values-based work that was like, how important to you is it that you get good grades? Why is it so important to you? Oh, there's actually other things that are more important to you. Okay, how can we support you in decreasing the level of anxiety that you feel, coping with the anxiety, and challenging the self-talk that is like, I am a failure if I get a bad grade, and instead is rooted in like, well, actually, school isn't the most important thing about me. For this teenager, her faith was the most important thing about her. Um, so we talked about that being where her identity and value came from. That isn't going to map on very well to the anxiety that some of my other clients face, this being individualized to her. And for other clients, that anxiety, the work that we do around anxiety is going to look very different. So again, important that we're really like focusing on understanding the individual and creating a treatment plan that addresses the needs of the individual rather than that addresses the diagnosis that we gave them. So again, this is the our introduction to the golden thread. We'll talk a lot more about this when we do that case formulation, case conceptualization, closer to the middle of the semester. This is part two of where you will be taking what we were going to have as a class discussion and instead writing it out. And so the question is going to be, what is the difference between observation and interpretation? Why does observation versus interpretation matter? And you're going to be bringing those questions to this image, and you will be observing this image, telling me what you observe about it, and then you'll be telling me how you might interpret what is going on in this image. So this will be another component of your individual work. And then this is the last one, because wait, I have another thing for us to talk about, and that is psychological theories. So my question being, well, I guess questions, I've got three of them. What psychological theories can you think of? When I say this, what I mean is like the cognitive behavioral theory, or psychoanalytic theory. And I'm curious which theories resonate the most with you, which I think is really important because there are really exciting ways, okay, exciting to me, that our theoretical grounding can impact our assessment, diagnosis, and treatment planning. For now, I want you to think about, hey, what are the ways that my feminist approach to psychotherapy might be a grounding force or a guiding force in how I look at assessment, diagnosis, and treatment planning. So, the first question, I really would like you to just like come up with a list of like every like treatment modality theory that you can think of. And then think about which ones resonate the most with you. What is the work that you want to do with your client? What is the foundation that you'll bring to therapy? Um, and then think about how might that impact the assessment, diagnosis, and treatment planning that you do. Okay, so our next topic, and again, we're kind of flying through information here, and I wish we had the option to pause and answer any questions. But moving forward, um, I want to take a little bit of time to talk about assessment and the therapeutic relationship because we build the therapeutic relationship with the client from our first interaction with the client, right? The first time that we meet them. And generally, the first time that we're meeting them, we're doing the assessment. That is the beginning of our work. We don't start treating before we have done the assessment so that we know what we're going to be working on. So, how do we at the same time gather the information for the assessment and build rapport? Particularly because getting the information for the assessment can feel like you're interrogating a person when you're like, okay, tell me about your early childhood. Yeah, when did you start going to school? Where did you go to school? Did you move? Who did you live with? What was it like move? Right? Like it can feel like you're asking a ton of questions to get the information that is asked from you in an initial assessment. So we have to think about how we go about doing the initial assessment so that it isn't like super intense asking a bunch of questions, but instead feels like we are building rapport and building a relationship in the asking of those questions, in the gathering of this information. Um, and so some ideas on how we do that. Um, and these really come from motivational interviewing, which you're going to be watching a couple of videos about motivational interviewing for next week. Um, but this comes from active listening, showing that you're interested, showing that you're following along with what someone is saying, empathic responding, feelings validation. How do you show the client that you understand how they felt in the moment? And then nonverbal responses. When I first started working, I worked with a lot of teenagers who were coming out of hospital-based placements, and a lot of them expressed concerns about like therapy being like talking to a robot. Um, and wanting to feel like they had a real connection with the person who was their therapist. And I am I'm too goofy to be a robot. No one would program a robot like this. Um, so my ability to provide nonverbal responses and be present in the moment and be authentic is was really helpful, right? Like sometimes we think about like you have to have a mask for when people tell you information. And like sometimes, yes, I have heard things that I've been like, there have been times when during COVID when I was grateful I was literally wearing a mask because I was like, oh, I would need to school my expressions while learning this information, and that would be really hard to do. So thank goodness I can just under the mask be like, right? But like no one can see that. Um, but sometimes it's like something crazy happened to your client. My client doesn't want me to be like, oh, okay. They want me to be like, what? So again, it's kind of how we show our personality as well, and show that we are fellow humans walking on earth with them. Cultural humility is always important to recognize, um, that we're we're never right. The term used to be cultural competence. We realized we will never be competent in understanding the lived experiences of people when we have not lived those experiences. So coming to this work and these relationships with humility to learn, and to accept that things are going to be different in different cultures. And I mean cultures in the sense of like an individual's family culture and how that family operates in that family system to the more broader consideration of cultures that we often think about when we think about people from different nationalities or racial or ethnic backgrounds. Um, and then respect for client self-determination. I, in particular, am really big on this one. Um, and it is part of the reason that I love working with teenagers, and part of the reason that sometimes parents don't love it when I work with their teenager, because I will not have a person in therapy who does not want to be there. I won't do it. If a client, I have plenty of teenage clients who are excited to be in therapy and want to have someone to talk to. And when I have clients who are like, no, I don't want to be here. I don't understand why my mom is forcing me. I'm like, ooh, I'm not interested in that because how is this respecting what you want for yourself? And the outcome is usually they don't like therapy because they were forced into it. So why would they want to go to therapy in the future when it's something that they were forced to do in the past? Um, but respecting, like I don't make the goals for therapy. I don't decide what we're going to work on. We decide on it based on what the person's goals are and what they want for themselves. So just because a client is struggling something doesn't mean, oh, that's automatically the goal, right? Like I have worked with clients who struggle with substance use, and that's not the goal that they want to work on when we start therapy, right? So that's not the goal that we work on when they start therapy. Usually it becomes a goal after a while when we realize that, whoa, we've done a lot of things to work on your anxiety, and your anxiety is not budging. What else could it be? Oh, could it be that smoking marijuana all the time actually heightens anxiety when you thought in the beginning that it calmed your anxiety? So maybe we do want to work on that as a goal. Sure, that absolutely happens. But really meeting clients where they're at and being like, if you want this to be a goal, it's a goal. If you don't want this to be a goal, it's not a goal. Of course, unless that thing is safety. If you're like, it is not my goal to stay alive, I'll be like, well, it is my duty to support you in remaining alive, right? So if that's someone's goal, we're probably not working with them in an outpatient. If it is their goal to not remain alive, we're probably not working with them in an outpatient setting. That wouldn't be an appropriate level of care for them. And don't worry, we talk about level of care when we discuss treatment planning to also be mindful of, is this client's goal something that we can support in the environment or level of care that we are at, right? So right now I am an outpatient in the level of care. I used to work in an intensive in-home program, and we could take on more intensive risks, provide more intensive support in that program. So these are my thoughts on assessment and the therapeutic relationship. If this is something that people want to talk more about next time that we meet, I'm really happy to do that. I think this is a really important part of how we approach assessment with people. So, an important piece. Okay, the first session, again, I'm just kind of like drilling into this because I know you'll have talked about the first session when you think about orientation to counseling, but I want to also now, like, if we're really adding in the piece where you probably need to gather assessment information about this individual quickly, then we really need to focus on what are we doing in that first session. In the first session, we are working on assessing the client's presenting problems, thinking about the goals for therapy, and what were the previous efforts at resolving problems. Just going back, part of the reason that I'm kind of so intense about the first session is that when I did intensive home-based work, we had 1 month to write the assessment and the treatment plan. So we could meet with that individual like 4 to 8 times before the assessment and treatment plan were due, due based on what our funding source, which was DMH, required. Now I work in outpatient therapy, and the funding source is insurance, and they require the assessment, diagnosis, and treatment plan after the initial session. I need to have that right away. So those first 60 minutes that I get with the client are really important. There's a lot of information that I'm supposed to get out of that time. So, um, little review really of what I'm sure you went over in orientation to counseling, which is professional and ethical issues of the first session. Um, Dress professionally, present yourself and your credentials. Um, and particularly make it clear that you are well, to start, that you are a practicum or a student or an intern working under the supervision of a fully licensed individuals. Um, handle as many discuss as many boundaries as you can in the first session, right? Like starting on time, clarifying your policy on lateness and cancellations. You want to be as upfront about this as possible because setting boundaries from the start is much easier than trying to enforce boundaries later. And then, of course, we always discuss confidentiality, the privacy and limits to confidentiality. We go over informed consent. Clients need to know about the nature of the treatment so they can choose if they want it. So sometimes you'll have the person fill out the paperwork, all of the intake and consent paperwork in the first session. Sometimes they fill it out beforehand, but you want to make sure that you go over it either way and give kind of the highlights of, here's what you've signed, here's what you've agreed to, here's the policies that will inform the work that we do together. So the stages, that is all kind of the introduction stage of the first session was all of that. Um, Introducing yourself, how the client likes to be addressed, making conversation or small talk while walking to the office. Um, I find this is like maybe the most painful part of therapy to me is when I like see the client in the waiting room and then they stand up and then we walk back to the office together and then I'll ask like, "How are you today?" And then like the answer that they give is like just a throwaway. It's like, oh, I don't know, we're walking through the office. They're going to be like, "Oh, I'm fine." And then we get down and to my office, sit down, and I'm like, "So, how are you?" So maybe you're better at making small talk than I am, hopefully. Um, okay, directing people to the appropriate seat, presenting your credentials, blah, blah, blah. I went over all of that. Okay, so then we always ask this question. What brings you to counseling today? And in the reading, there's a like pretty lengthy overview about why we ask this question specifically. Um, and I kind of like it as like this uh I don't know, poetic deep dive into what all of these words mean. Um, but basically, it's why are you here and why are you here today? Why now? And then so I have had the experience where I ask this question, I get like a two-word response, and then a lot of follow-up questions are necessary. I have had the experience where I ask this question and I say nothing else for the next 57 minutes. Um, and you're probably like, Sarah, if you say nothing else for the next 57 minutes, how do you gather enough information for the intake assessment that you have to do? Such a good question. Um, We're going to approach the intake assessment in this class as if we had all of the time in the world to ask every question that we wanted to ask. In reality, I put into the intake assessment the information that I am able to gather, and the information that I gather along the rest of the way in my time with that client will either be noted elsewhere in the chart, whether that's in a progress note or a chart note, or it will be in an updated version of the assessment. Um, and again, we start with that question, then we can um, gather information by asking more specific questions, learning more about the client. We want to spend a little bit of time closing with the client. We don't really want to just be like, oh, and that's our time today, right? We want to give a little bit of time to like tie up a little bow on our first session. And in that little bow, we want to provide a summary of what we talked about. We want to be a little bit like, okay, yeah, I would be excited to work with you on these things. I think that, like XYZ, I can see that, this is something that you're motivated to make changes in this area, etc. So again, you have to be mindful of watching the clock and managing your time throughout this, guiding them to like, okay, we're going to end session and I will see you next week at the same time, or whatever the plan is for the next session that you have with that client. We're actually next time, well, I guess here we go. So you're gonna watch for next time, a clinician going through a first session with a client, gathering information about the client, working on treatment planning. And then when we meet next time, you're going to do a role play with a fellow student, and you're going to take turns being the client and being the clinician, and going through an initial session. Okay, assessment person purpose. Okay, so this is where we're answering the questions that were asked for you to answer individually earlier. So, um, hopefully, hopefully, if you didn't know when you were thinking about it earlier, it'll feel a lot clearer after these slides. Um, I'm not answering the same questions for diagnosis and treatment planning until later in the course, so I will be most interested to see how you responded in those areas. Um, okay, basic objective of the intake interview is identifying, evaluating, and exploring the client's chief complaint or their presenting problem and their associated therapy goal. We're gathering data about the client relating to their interpersonal style, their interpersonal skills and personal history. So, and then we're evaluating their current life situation and functioning. So, to kind of think of these three bullet points in a different way, it's like gather information about presenting problem, gather information about this person's history and past, and then gather information about what is going on right now for this client. We're working all the time towards case conceptualization. How are we going to weave all of this information together into our understanding of the client? Um, and that case conceptualization. See, this is where I forgot that I put in the PowerPoint more information about the case conceptualization. When I was talking about the golden thread, I made it sound like we weren't coming back to this for weeks. And here in the PowerPoint, I have more information about the case conceptualization. Um, I wonder what kind of memory that means I'm missing. Um, the case conceptualization is if those were all the basic objectives of the intake interview, or of the assessment, what we want the assessment to do is then point us towards this model or representation of the client that becomes our case conceptualization. This is the hypothesis about their client and the problems, generally based on one or more theories, and becomes the basis of the treatment plan. So I have a client who is 35, and I have her diagnosed with generalized anxiety disorder. You could make an argument that we could add an OCD diagnosis, and there are a lot of different areas where this anxiety pops up. It comes up around food and potential food contamination. It comes up around any medical issue, whether that is like a symptom that is being experienced or a medical procedure that needs to occur or getting her blood drawn. And this anxiety is also manifesting in current fertility journey and IVF treatment. And will she get pregnant? Will she be a good mom or cause harm to the child if she becomes a mom? So there are like all of these different content areas where the anxiety comes up. My hypothesis about all of this is actually that it stems from the trauma of suddenly losing her dad to cancer when she was in high school. So, experiencing that sudden and unexpected trauma, which was unexpected because her parents did not tell her about the severity of his diagnosis. And then, following that event, she experienced homelessness because her mother was no longer able to provide that secure base for her. She was on her own. So there was a lot for her in then trying to navigate, can I keep myself alive as I try to survive um, these experiences of loss and really being on her own. So while we could focus on like these different topical areas of anxiety, I tend to view a lot of things through a trauma-based lens. So instead, we work on some more of that, like understanding how trauma impacts the brain. We work a bit more on how do we regulate the nervous system. We work a bit more on like what are the core beliefs that this event taught you? How are they showing up now? And what kind of post-traumatic growth might we actually be able to look back on, identify, and use as strengths moving forward? So this case conceptualization becomes the basis of the treatment plan, again, because my treatment plan is not like, okay, let's talk about why you actually shouldn't be anxious about preparing a pepper that has a spot on it. And we're going to actually focus on like, can you, like, like the treatment plan is being based off of my understanding of the client rather than just here are the diagnoses or here are little problems that keep popping up. So, what information are we trying to gather? This is the biopsychosocial assessment that you will be writing up a couple of times. Um, you will be writing this up, you'll be putting in some information from some of these areas for the role play videos that you're going to watch for class asynchronous class next week. You're going to be writing this up from the role play that you will do in class with a partner, and then you'll be writing this up for your semester project character. So we're going to get a lot of practice in gathering this information. We're going to get practice in clinical writing, and we're going to hopefully begin to get practice in how to be succinct because you do not have time to have a 19-page assessment document from a ton of information. You don't have the time to gather that much information, and you certainly don't need to be writing that much. So, we're going to work a lot on this skill. Next time that we meet, we're also going to talk about some uh, tips for clinical documentation. How do we do clinical writing? What do we include? What do we not include? So, more on that to come. But in our initial assessment, we will be including client initials, date of birth, gender identity, primary language, date of the assessment meeting, person present at intake, um, your name, who was completed by, sources of information, and then okay, we've got all of these little sections. Actually continues um, on, actually, don't worry about the next page. So, one thing I want to highlight is that my expectation when you fill out this biopsychosocial assessment, um, for some, um, for some assignments will be as much of the information in all of these sections that came through in the video or came up in your role play with your client are getting included in here. I'm in those two situations also going to want you to be mindful of what is asked on here that was not addressed in the video or was not addressed in the role play that we did, right? So like if you have this role play and then you realize that you never asked who else lives in the home with them, you're going to make a note. I didn't gather the information about who else lives in the home with them. If I had more time, I would have gone back and asked who lives with you in the home. Um, for the semester project, you'll be expected to include all of this information. So, like if you were writing this about Shane Hollander from Heated Rivalry, um, you would make up any information that you didn't know. So let's say I don't know about and it's not clear if his parents have a history of mental health diagnoses or treatment. I would make that up. You could be like, sure, his mom is anxious, she's seen a therapist. Or in that event, you could also be like, no, there's no history. So where you don't know, I would have you make things up. Um, but definitely take time to read over this. Read over it, see if you have any questions about what is asked throughout here. It's a lot of information that it covers. Some things that I just like to point out are client development, social history, significant events during childhood, education, significant family history, family of origin composition, social interactions, and romantic history. Really important section. I want you to make sure that even when you're working with an adult client, you're gathering that background information. Interpersonal strengths is all, or skills and strengths is all about their connections and relationships. And then other strengths and protective factors, we have, like what are their interests, but also making sure that we cover cultural and religious background. We're covering meaningful activities, community resources, and supports. Later on, we will be taking this information that we've gathered and we'll be using it to di create the diagnosis and write the clinical case formulation. Um, these will come a little bit later in the course, but just it's helpful to keep in mind the information that I am gathering, I am going to use to create a diagnosis. So part of the reason that this is helpful is that in here, right, like current physical health, medical conditions, one thing that pops up a lot in different diagnoses is questions around how the person is sleeping. And questions around restlessness, questions around their appetite. So knowing if I'm like, oh, I think we're on track for an anxiety diagnosis, I might also ask, like, how is your sleep? Are you having any difficulty sleeping? I might ask about the physical symptoms that they associate with the feelings of anxiety just to make sure that when it comes down to like, I'm going to be asked to make sure that they have three of this list of symptoms, that I can say, yes, I asked about that. They have these symptoms. Okay. And then another thing that is going to come up is how we're going to go about approaching an intake interview is, I would say, unstructured to semi-structured. The structure really being, I know the information I want to gather. I'm going to ask questions to get me the information that is in this assessment that I'm asked to write up. I think it is helpful to note that that is one style of doing an intake interview. There are also far more structured uh, styles or methods, like using a diagnostic interview schedule, which gives you, here are the questions that you're going to ask. Um, Unstructured would be like the time that I was like, what brings you here today? And then no more responses required from me for 57 additional minutes. That was completely unstructured. That person just shared. And then we've got semi-structured where we kind of guide the client through. Here are the areas that I want to cover. Semi-structured might also include here's an assessment tool that I want to use to make sure I get this specific information from the client. So when I was doing in-home work, every client was given the PHQ-9 depression screening and the GAD-7 anxiety screening. They all had to fill those out during intake, so that provided some additional structure and was honestly really helpful because, again, when I forgot to ask about sleep, it asked about sleep. When I forgot to ask about appetite, those things asked about appetite in a way that made diagnosing much easier. We're going to be talking more in a couple of weeks about assessment tools, and then we'll also be doing assessment tool presentations in class, talking about a chosen assessment tool and how you would use it with your semester project character. So, excitement to come. All right. So, I did not include in here that you have homework related to those three areas I brought up in the uh, PowerPoint, where I'm going to have you submit your answers to some questions. So that will be added in here. But for next week, as we kind of reviewed the beginning of class in Canvas, you'll start by clicking class 3, start here, and that will walk you through what you need to do for next week. For next week, you'll be doing a discussion post on difficult questions or topics. You've got a couple of readings to do. That difficult questions or topics is thinking about questions that feel most challenging to ask about how you can become more comfortable talking about these topics and responding to at least one peer's post. And then again, this is what that class 3 start here looked like with the discussion post that is due, and then readings and the videos to watch. I think I might have said earlier the videos to watch are due next week, but clearly I'm kerbobbled. I am all kerbobbled with the snow and it's Tuesday, but I haven't been into the office yet this week, and school's been closed the past 2 days in Boston, and there's a lot to wrap our heads around here. But when we meet in 2 weeks, um, I will be very excited to actually get introduced to all of you. Um, And please be sure to write down any questions that you have, anything that felt confusing, so that we can definitely be sure to address those things at the start of class. Um, each time that we meet, I'll go over what is due next week and what is due in 2 weeks. So, due for next week is that discussion post. Due for 2 weeks is the write-up on the sample intake videos. So, it's these videos, part one, two, and three, that you will be watching, and then you'll be writing up these sections from the biosocial assessment. So you're just going to write up identifying information, demographics, and presenting problem history and history of symptoms. You're just going to be writing up those two sections, and then you're going to write a reflection on the session about what you liked and didn't like about the psychologist. His name is Dr. Todd L. Grande. I don't know why I included his middle initial, but I was feeling very official at that point. So um, you're going to talk about that. Make sure that the reflection portion, just the reflection portion, is 500 words, and then however much information you have for those first two sections. And that is what will be due February 10th, which is the next time that we will meet face to face, slash the first time that we will all meet face to face. So, in review, we talked a bit overview slash laying the groundwork and foundation for continuing to talk about assessment, diagnosis, and treatment planning. You'll have an additional small assignment to do based on class being canceled for this evening. Please reach out to me. I think I'm very responsive via email or on Canvas. Um, Part of the reason that I think that is that I also work at Framingham State as a program coordinator, so I need to be on my email a lot of the time. Um, some professors don't have as much work at Framingham, so they are not on their email as much. I think of it as a benefit to all of you that I am glued to my email. So um, I am generally quite available. I do answer emails on the weekends. So if you're the kind of person who is like, yeah, the weekends are when I have all of the time to do work for this. Honestly, don't be shy about emailing on the weekends. I work a lot of different jobs, so sometimes that means I have to do a couple hours on the weekends. All right. So again, reach out with any questions, and I really look forward to meeting you all in 2 weeks. Thanks.